Good afternoon, everyone. Thank you for joining us. Today we are joined with Jonathan Pattenberg from Wintergreen. This is our first in our series of board education webinars. This has been a topic that our office has wanted to work on for many years, and we've really just struggled with what's the best way to provide information to hospital boards or critical access hospital boards. And so we've landed on doing webinars, recording them, and then putting them on our YouTube channel. Over the past couple of years, we've really increased our webinar offering, and so we thought this might be the best way. Therefore, we'll record today's webinar, get it on YouTube. You can share it with your hospital board members. It's also going to be on there, so it's on demand for folks. So if you have new hospital board members, we're wanting to make a resource that you can share with them to say, hey, here's some background information. As mentioned earlier, this is our first swipe at this. We have 3 webinars scheduled. We have today's. We have one next week with Corey Loomis, who's an attorney in Oklahoma City, and she will be talking about rights and responsibilities as a hospital board member. And then Dr. Bavette Miller from the OSU Center for Health Sciences Healthcare Administration program will be talking in December about management versus governance. And so from there, if there are other topics that you're like, hey, we need to talk about this or we need more information on it, let us know. We want this to be useful and a good resource for you and your hospital board members. With that said, I will turn it over to Jonathan. We are a small group, so if you have any questions, please feel free to unmute your line or put in the chat your question or comment. So with that said, Jonathan, I'll turn it over to you.
Thanks, Laura. I'm excited to do the kickoff to the governance series. So as Laura had mentioned, what we're really looking for is to find different opportunities and different strategies around how we can start to leverage and improve operations as a whole. So Laura mentioned, my name is Jonathan Pattenberg. I'm a principal with Wintergreen, Inc. We are a rural-focused organization that really looks at how we can leverage rural opportunities to improve financial solvency and outcomes to ensure that those facilities can continue to provide the vital services within those communities. Now, the information that we're going to talk about today is really a CAH Cost Report 101. Now, when we think about it to this degree, what we're not going to do is get into all the specific forms. What we're going to talk about is how the Critical Access Hospital's cost report plays a major role on reimbursements received and ultimately the services that we can provide as an organization. Now, again, there's different ways that we can leverage the cost report to really ensure the solvency of our organization going forward. Now, as we talk through the information today, first what I'm going to do is give a very high-level overview of the Critical Access Hospital program. Talk about the intent, the purpose of the program, and really how it came to fruition because of the state of the healthcare environment that was occurring in the past. Next, what we're going to talk about is CAH operational regulations. Again, the Critical Access Hospital program has certain requirements that we have to maintain in order to continue that designation. Now, oftentimes when we're dealing with boards or different people in leadership positions, we'll get questions around why we can't expand certain services and why we can't do this and why we can't do that. As we talk about the regulations today, we're going to do it through the lens of, again, how we can leverage the cost report as a part of that decision-making process. Then what we're going to go into is the CAH reimbursement methodology. Now, as we talk through the methodology, what we're really going to be looking at is how this methodology differs from probably anything else you've seen from a business environment. And it very much goes back to that cost-based nature that critical access hospitals receive from Medicare and in many states, Medicaid. And the underlying theme as we continue to go through all of these different conversations is really how the cost report works. Now, when we think about a Medicare cost report, I always like to start the conversation by saying to think about the cost report as a personal tax return or a business tax return. The goal and the intent of the Medicare cost report is really to calculate and define the expenses and the revenue that we receive as an organization, as a critical access hospital. Now, when we use that framework as that critical access hospital's cost report, as we continue to work forward, and you think about from a tax return type approach, we're going to key in all of these numbers and all of these different values into that cost report. Now, depending upon the information that we file within that cost report, will ultimately determine at the end of the year, are we a settlement where Medicare is going to send us a check for money, or are we going to owe money back to Medicare because of that cost report? Now, when we think about a cost report as a critical access hospital, the goal is to ultimately determine the cost that is proportionally allocated for that Medicare patient population. So again, at that very 50,000 foot view, if 40% of our business is Medicare, then roughly 40% of the reimbursements that we receive relative to the cost would also be Medicare to that degree. So again, there's always that correlation and that rate titration of our Medicare rates depending upon our cost structure within that year and depending upon the volumes and the payer mix for the patients we actually see. Now, when we talk about an overall performance model and how the cost report fits into the organizational structure, there's many organizations that will say, we want to manage our organization to the cost report. And really, that is one of the biggest mistakes that we can make as an organization, is to try to manage operational based on the settlement or the outcomes tied to the cost report. What we want to look at for the cost report is, again, realize that it is one tool of 1,000 different tools that we can leverage within our organization that will drive reimbursement coming forward. But what we don't want to do is we don't want to make decisions because of the cost report ramifications. We want to make decisions based on what we can do to sustain services, the patient population, and all of those different factors, and then leverage the cost report as a way to improve financial outcomes. So again, we don't want to manage based on the cost report. We want to leverage the cost report based on how we want to perform as an organization. Now, when we ultimately look at a critical access hospital, or frankly, any organization that's providing healthcare services, everything rolls back up to the value to the community. And as we're sitting there as a board, that's really what we're assessing, is to ensure that, one, from a governance approach, the services that are provided are being done in a compliant and competent way, but also to ensure that the value for the services is being derived from the patient population. Now, there's many different buckets that all these things can fall into. We have our overall strategy, which really drives the direction for the organization as a whole. And then we have our operations. And that's really all the day-to-day services that we're providing, both directly to the patient population, but also all the services that we're having to provide internally to continue to sustain those services going forward. Everything from revenue cycle to administration to dietary to all of those different ways, housekeeping and so forth, all roll up under the operational configuration. Now, when we look at the services and those forthcoming forward, it really breaks down into two different areas, financial and quality. Now, when we look at those different areas, quality very much gets into the performance improvement, the outcomes, and so forth. On the financial side is really where we start getting into a lot of the different nuances as to how we can leverage the cost report going forward. Now, the key drivers in the cost report comes down to really revenue and expenses at the different departments. Now, there's several different worksheets that will dictate how we allocate all those different expenses and how we look at revenue and so forth, but they all generally roll up to each of the different cost reporting centers. Now, when we think about the cost reporting centers, there's really two ways to break it down. You have your administrative and overhead. That's your administrative in general, your facility costs, dietary, cafeteria, nursing administration, and all of those different departments. And then you have your revenue generating departments, your emergency department, your acute care services, swing bed services, and all of those different programs. Now, one of the fundamental things for what the cost report does is it allocates all of those non-revenue generating departments, the A&G and all of those different departments, to the revenue generating departments. And this is calculated through a step-down methodology. Now, the step-down methodology varies depending upon what ultimately we are trying to step down to the different departments. Some of them, such as facilities, are stepped down based on square footage. Some of them are stepped down based on salary expense, such as our benefits, and so forth. Now, when we look at all of these different nuances, again, it's the realization that we have to determine the proportional expense attributed to the Medicare patients. Again, that's really the goal of the cost report, and also to determine the total cost and revenue for the facility as a whole. Now, as we step down those expenses, it changes what the fully allocated or total allocatable cost is to each individual department. And just think of it similar to an overhead expense. Now, as we're having those different conversations from a governance approach, and we start to look at all of the administrative expenses, and we're getting into the budgeting process at the end of the year, it's important to realize that all of those different expenses from an overhead approach will ultimately find their way down to the different cost centers, both your revenue generating departments and other cost centers. So it's really critical to look at it to that degree. Now, when we talk about the critical access program as a whole, if we go back to when the program was founded, which was in 1997, there was expected to be about 300 critical access hospitals across the country. However, as we've continued to see rural closures across the country, there has been a substantive increase in the number of critical access hospitals across the country. And as of recent, I checked last night, there are currently 1,362 critical access hospitals across the country. Now, the intent of the Critical Access Hospital program was to provide critical access hospitals with an alternative reimbursement to ensure that those hospitals could remain open and provide those vital services. And as you get to many rural communities and you go across the country, particularly in states like Texas and Oklahoma and Montana, where there are significant distances between hospitals, many of these hospitals are truly safety net providers. And to ensure that those organizations can continue to maintain services going forward. That was really the intent of the Critical Access Hospital program. Now, the core difference between the Critical Access Hospital program and the other PPS, your prospective payment system hospitals, which are your large tertiary facilities in Oklahoma City and Tulsa and so forth, is that your Critical Access Hospital programs get cost-based reimbursement. Your PPS hospitals get a fee-for-service reimbursement rate. Now, all hospitals have to fill out a Medicare cost report. However, for your critical access hospitals, the cost report has a direct impact on the reimbursements that you receive as an organization. So oftentimes for those PPS hospitals, your cost report is more of an administrative function or something we have to do on an annual basis. For the critical access hospital, that cost report has a direct impact on the reimbursements that you will receive. And it's not purely just an administrative task, but also drives those reimbursements going forward. Now, when we look at the cost report, there are definitely ways that we can optimize the cost report to increase reimbursements based on making things more accurate. So as we've looked at critical access hospitals across the country, what we've come to realize is those organizations that view the cost report as just an administrative task are often leaving money on the table from a reimbursement approach. Those organizations that view the cost report, again, as a tool often fare better from a reimbursement approach because they tend to be more accurate. And what we've seen is generally the more accurate that we're presenting the information in the cost report, generally it will benefit us from a reimbursement approach. Now, when we look at an overview of the Critical Access Hospital program, again, the goal was to ensure the continued solvency of hospitals going forward in those rural communities. Now, critical access hospitals have certain limitations. We are limited to no more than 25 beds that can be used for either acute in-care, delivery services, swing bed type services, and so forth. We can't have a greater than 96-hour length of stay. So all of those acute care patients will generally have to have a length of stay of less than 4 days. And again, the goal is again, not to truly establish these massive facilities within rural communities, but to give them that reimbursement advantage to ensure that they can maintain those services going forward. Now, there's been many changes over the prior years relative to the Critical Access Hospital Program. Now, in today's times, again, we can have up to 25 beds. We can actually have 101% reimbursement tied to all of those services. We can offer distinct psych or distinct rehab units. It also affords us, again, as critical access hospitals, because of the cost structure that it takes to operate in rural communities, it also starts to provide us reimbursement for on-call services, particularly relative to our emergency room. Now, again, the emergency room services are one of the core and critical services that we have to provide as a CAH. And because of the cost associated with those services, Medicare has also stated that we will allow you to recover some of the cost of those providers while they're on call providing services. Now, when we talk about the Critical Access Hospital Program, one of the things they took away back in 2006 was the ability to qualify as a necessary provider critical access hospital. Now, a necessary provider critical access hospital was a critical access hospital that was deemed by the governor to be of a certain provider status that allowed them to not have to meet the critical access hospital distance requirements. Now, a critical access hospital in today's times that is not a necessary provider CAH has to be greater than 35 miles on primary roads or 25 miles on secondary roads, 15 miles, sorry, from the next closest facility. And if you do not meet that distance requirement, then you cannot operate as a critical access hospital. Prior to 2006, the governor could actually designate you as a necessary provider critical access hospital, which would allow you to not have to meet that distance requirement. So many of the critical access hospitals that are operating in today's environment, it's important to realize whether or not you are a necessary provider CAH or a traditional meeting the mileage requirements critical access hospital. If you are a necessary provider CAH, the thing I would caution to you is you want to ensure that you do not do anything that jeopardizes that critical access hospital designation. So if we're establishing off-campus practices or we're looking at doing a relocation or whatever else the case may be, we want to ensure that we continue to meet that necessary provider designation. If we do anything that jeopardizes or causes us to lose that necessary provider designation, we will not be able to recover that going forward. Again, and it could cause us to lose that CAH designation and the cost-based reimbursements that is associated with it. Now, as we continue to move forward, there have been changes as we've continued to progress forward as a critical access hospital. In 2010, they added the ability for critical access hospitals to qualify for the 340B program. They extended the Medicare Rural Hospital Flexibility Program. Now, the Flex program is a program where certain funds are set aside to specifically focus on the improvement in the outcomes of critical access hospital. Now, the program came to the realization that oftentimes these rural hospitals do not have the staff or the resources similar to many large systems and organizations. And they wanted to dedicate resources to ensure that those organizations continue to move forward and to realize benefit and outcomes associated with the services that they're providing. Now, many states have leveraged these funds to drive specific initiatives and outcomes, drive certain analysis and so forth. But nonetheless, it is an extremely valuable program that is afforded to the critical access hospitals going forward. Other healthcare provisions that we've seen that have impacted critical access hospitals, the accountable care organizations, reduced PPS hospital reimbursements, increased insurance in rural areas. Now, when we talk about the organizations and the impact on things going forward, and we talk about the critical access hospital program, because there is that direct correlation between the services that we provide, the cost to provide those services, and the reimbursement rates that we can receive, it is extremely important to understand how the cost report plays into impacting all of these different areas. Now, In today's times, particularly driven by the accountable care organizations, is we've seen a decline or a reduction in the reliance on many of our critical access hospitals to provide certain services. And oftentimes it comes down to the cost of care to provide services in those facilities. For example, if our cost to provide care in a swing bed service is $1,300 a day, but then a PPS hospital or some other post-acute care type facility can provide that for $500 a day, the insurance companies are going to try to move the patients to that low-cost provider. And this is one of the issues or the concerns with the critical access hospital program is, again, as we reduce cost or we reduce the volumes, there is a direct impact on the reimbursement rates going forward. So in many of those system environments, as we see a reduction in the volumes that are sent to that critical access hospital, it just increases the cost of care for the other Medicare patients that are receiving services at that facility. So when we look at our critical access hospitals, I always like to say that they could be the most expensive or the cheapest provider of care within healthcare. And that's, again, because of the titration of that rate. So if we're able to increase volume and keep costs relatively the same, the cost per unit of service will go down. If volume goes down, then again, that cost goes up. So oftentimes when we're thinking about it from a governance approach, volume is very much the solver for many of the issues that we're having as a critical access hospital. If we're able to increase our volume, we will often see a material improvement in our reimbursements and our financial position because of that approach going forward. So again, look at that as a means to how we can improve our financial performance going forward. As mentioned earlier, there are currently 1,362 critical access hospitals. They make up 25% of all of the acute care hospitals across the country. Now, even though they make up 25% of the total hospitals, they are only 5% of the total inpatient and outpatient payments for those facilities. So we often talk about the cost of care at those facilities, but they are not the bulk of the total cost or the healthcare spend in those different areas. Now, there has not been much of a push to attack or go after the critical access hospital program, even though we see cuts coming across the country relative to many of the hospitals. Critical access hospitals have mostly been held harmless in those different areas. Now, again, they still experience things such as sequestration, they still experience other revenue cuts, but they've probably been held harmless that many of the PPS hospitals have experienced. We've seen a material increase in the number of CAHs since 1997, since the implementation. But nonetheless, many of the laws that we've seen come out have not directly impacted the critical access hospital program. They've gone after many of the other programs. But nonetheless, as a governance approach, again, we want to look at ways that we can improve the financial solvency for our organizations, and that is often accomplished by leveraging the designation, driving reimbursements, providing adequate services going forward so that we can continue to increase reliance on that facility. Now, when we look at the operational requirements attached to a critical access hospital, again, this is a federal designation under Medicare as a separate designation from the other ones that are afforded to hospitals. Now, the other designation types, you have straight short-term acute care facilities, Medicare-dependent hospitals, sole community hospitals, rural referral centers. There is no one-size-fits-all approach for designations for hospitals across the country. We want to ensure that we leverage the designation to ultimately improve the financial position for our organization. Now, when we look at the Medicare conditions of participation, to continue to operate as a critical access hospital, we have to operate fewer than 25 inpatient beds. Now, again, we can't operate a 10-bed distinct site. We can operate a 10-bed distinct rehab unit, and we can also operate a distinct observation unit. But our true inpatient beds dedicated to acute care services and swing bed services cannot be in excess of 25. We have to maintain an average length of stay of less than 4 days. And again, this is across the total blend of all of our acute care services. So you can have one patient that stays there at 5 days and one patient that stays there at 2 days, and the blend of them together would be less than 4 days. We have to offer 24-hour emergency department services, lab services, and diagnostic x-ray services. Now, providers, when we're offering those services, a provider has to be on site and be able to provide those services within 30 minutes of a patient presenting. So again, what we can't do is say, oh, we offer those services, but our provider is an hour and a half away. We have to continue to operate those services to maintain our CAH designation. We have to be located in a rural area, and we have to meet those CAH distance requirements, being 35 miles on primary road or 15 miles on secondary roads. Now, when we look across all critical access hospitals, I would say the biggest concern or the biggest issue that jeopardizes the ability to maintain that CAH designation is the distance requirements. Oftentimes, a critical access hospital will open an outpatient facility, doesn't matter whether it's a rehab, primary care practice, a specialty practice, or whatever the case may be. If you try to operate that as a provider-based department, that off-campus location has to be at least 35 miles on primary roads or the 15 miles on secondary roads from the next closest hospital. Now, also, critical access hospitals, every 3 years, you have to recertify that you meet all of those CAH conditions of participation. And really what that means is every 3 years, Medicare is going to look at your facility and evaluate whether or not you meet those CAH conditions of participation. Now, as I referenced earlier, for our necessary provider CAHs, again, if we are a necessary provider CAH, we want to ensure that we don't ever do anything to jeopardize that designation. If that designation ever goes away, we would then have to qualify as a critical access hospital meeting the distance requirements. Now, when we look across the country, somewhere between 1,100 and 1,200 of all of the critical access hospitals in the country are considered or designated as a necessary provider critical access hospital. So an overwhelming majority of them are necessary providers. So that is a vital designation for those hospitals. We already talked about the off-campus requirements. Now, for the purposes of Medicare, when we think about on-campus versus off-campus, an off-campus department is anything that is greater than 250 yards away from the main hospital building. So even if you are on the main campus of a facility and you are 300 yards away from that hospital, you would be considered off-campus for the purposes of the critical access hospital program. It has nothing to do with whether or not you are at the same physical address. It has to do with distance to that next facility. We've actually seen organizations that are located across the street adjacent to the property, but because it's 250 yards from the main building, it is considered off campus. On campus is anything within 250 yards of that main building. Now, as we look at programs going forward, just because you do not meet the distance requirement does not mean you cannot own and operate an entity. You can still operate a practice, you can operate another unit. It just means you can't operate it as a provider-based department of that organization. Now, the reason why I'm really getting into the differentiation of provider-based versus non-provider-based is provider-based departments under a critical access hospital, because of the cost report, gets cost-based reimbursement for the facility side of the services. Now, when we provide services as a critical access hospital, we're able to bill two sides. We're able to bill a facility component, which is covering the cost of the facility, the electricity, the overhead, the support staff, and all of those different services. And then we're able to bill a professional service, which is for your physicians, your APPs, and so forth, to bill all for those different services. Now, the facility side under a critical access hospital, again, is cost-based and relies on the cost report. For the providers that are billing the professional services, that's all non-cost-based services. And we're billing the professional fees for those services. Now, when we talk about the technical versus the professional, when we look at the services provided by those different providers, we want to ensure that we're generating enough revenue to cover their cost. So again, all of the provider compensation and cost is not included on the cost report when we're providing those different services, and we're generating the professional fees. The technical side, which is again, the facility and all of those other costs, we receive cost-based reimbursement from Medicare for those services. And this is why it's very important from a cost report approach to realize the differentiation between the facility cost, the provider cost, and also the location of those services. Now I'm going to use rehab services as an example. Now, under a critical access hospital, our rehab services, whether it's a physical therapist, occupational, speech, or so forth, all of the services that we provide to a Medicare patient under a critical access hospital are cost-based reimbursed services, so long as it meets and is a provider-based location. If you operate a rehab department that is not within the distance requirements or on campus, then that facility or location would not receive cost-based reimbursement for those services, and you would have to generate professional fees to cover the rehab services time. So again, here's where the distinct nuances of the cost report plays into, and how the importance of the regulations ultimately determines what you will receive as a critical access hospital, depending upon the location of the services. Now, again, as I emphasized earlier, one of the worst things you can do is to try to bill for a non-on-campus service that, again, is not grandfathered or somehow locked in, but bill for a non-on-campus location under a critical access hospital as provider-based. That's really one of the worst things that you can do that will quickly bring to jeopardy your CAH designation. Provider-based clinics, again, some of the unique advantages under a provider-based clinic under a critical access hospital is, again, that facility side, you get cost-based reimbursement, and you also bill for the professional side. Now, if you were a straight PPS hospital, you wouldn't rely on the cost report as much for a clinic. For the clinic, you would receive a APC payment, which is a fixed fee. You would also receive the professional fee reimbursement. So this is where the critical access hospital and everything flows through the cost report has a distinct advantage when compared to other designation types. I'm going to pause for a second before I get into the specific nuances of CAH Reimbursement Overview, how the cost report works, and what I'm going to identify is 4 specific strategies that we can leverage that will ultimately allow us to improve our financial position based on how the cost report works. So I'll pause for a quick second. Again, if you have any questions, please submit them in the chat box. If not, I will move forward. All right, so not seeing any questions. Now, a CAH or Critical Access Hospital Reimbursement Overview. So as I mentioned earlier, critical access hospitals receive cost-based reimbursement for inpatient and outpatient services proportional to their Medicare population. Now, at that highest level, if the total cost for your facility is $10 million and 25% of your patient population is Medicare, Medicare will cut you a check for $2.5 million. This is, again, at the very 50,000 macro view level. Now, there's nuances when you get into coinsurance and all that stuff, but nonetheless, at that highest level, if 25% of your business is Medicare, Medicare will cover the cost of 25% of that facility's cost. Now, how are different ways that we can leverage this from a governance or growth or strategy approach? Now, an example I'm going to use is if we're looking at doing some type of capital initiative. Say we need a new CT scan, or we want to do a facility replacement or expansion or so forth. And we're going to spend $1 million on depreciation and interest a year. Now, what the CAH allows us to do because of that reimbursement methodology is any money that we expend that flows through that cost report, we will get the proportional allocation back through the cost report at the end of the year. So the importance of this is every year there is a reconciliation of the cost report, as I had talked about earlier, where you're either going to owe money back to Medicare, Medicare is going to owe money back to you, or if you're lucky and have somehow won the lottery, you exactly have a zero return cost report at the end from a settlement approach, you would be exactly break even. But as we continue to incur costs at our critical access hospital, we will get that proportion back. So if we spend $1 million per year and 50% of our patient mix is Medicare, we would get back 50% of that $500,000 in total a year just by incurring that cost. So again, how it flows through the cost report. So what I really want to emphasize here is, as a critical access hospital, we cannot cut our way to success as a critical access hospital. The cost report will not allow us to do it to that degree because, again, the rates will continue to go up. Now, this does not mean that because of the cost report, we can expend or spend money unnecessarily or just blow money. We still have to operate in a high performance perspective. It just means that our rates will continue to go up, at least for that cost report portion as a critical access hospital. So at the highest level, what is the Medicare cost report? The goal is it provides a financial account submitted by Medicare certified entities, including CAHs. And the goal is to identify your expenses, your revenue structure, utilization data for certain departments, facility characteristics, Medicare settlement data. Again, all of these different areas to ultimately determine and monitor the amount of reimbursements a critical access hospital should receive. Every year there is that reconciliation for that Medicare's critical access hospital's cost report. Now, many of you may be asking yourself, okay, we're getting cost-based reimbursement as a critical access hospital. Why is it we're still losing money? And the reason for that, again, is because as a critical access hospital and how the cost report works, the best we can do from our Medicare payer mix is to receive a break-even reimbursement from that Medicare portion. Now, to put this in perspective, when we look at the total cost of care, if the daily cost to provide an inpatient per paid unit of cost is $1,000, Medicare is going to pay us $1,000 for that patient. But if a commercial payer is only going to pay us $500 per day, then that means we're losing $500 every single day for each non-Medicare patient that we take. Now, this does not mean that we should turn away non-Medicare patients and that we should go 100% Medicare, because again, the only thing we can do is break even. What I'm emphasizing here is what we have to start to focus on is driving down the cost per unit of service. The way we make a profit as a critical access hospital is to drive down our Medicare reimbursements to a rate that is lower than what we're receiving from commercial. So long as our Medicare rates are higher than our blended commercial and non-Medicare rates, we will always lose money and have to pursue additional revenue opportunities, 340B, grants, mill rates to sustain through tax revenues and so forth. If we increase our volumes and drive down that unit of cost so that our Medicare rates is less than our commercial rates, then we can make profit on all of our commercial business. So again, the direct correlation between cost-based reimbursements and revenue and net financial position means that we have to focus on volume growth and expense management, with the primary driver being expense or volume growth more than the expense management side. So again, continue to look at opportunities as to how we can increase volume, because that will ultimately put us in a better position financially. Now, when we look at our critical access hospitals, and all hospitals to that degree, oftentimes we talk about total expense for the facility. And we say we need to cut costs within our facility, and that's the way that we're going to get to a financially sustainable position. This can be done to some degree within a hospital, but as a critical access hospital, we are limited to how much cost we can actually cut out. We have minimum staffing thresholds. We have facility cost. We have electricity. We have all of those different costs that we have to maintain on a day-to-day basis. So just to open our doors on a day-to-day basis, we have a significant upfront fixed cost. And our variable cost is really the only things that we can tweak over time. Now, the split between fixed cost and variable costs within a small hospital, particularly our critical access hospitals, is generally about 90% fixed and only 10% variable. So when we look at it to that degree, and we have 90% of our cost and 10% is variable, there is not much we can do to actually reduce the overall expenses for our organization. Generally, when we start looking at true expense reductions, we're looking at getting rid of services, shutting down departments, and so forth. Now, there are ways that we can do performance improvement and improve outcomes and streamline and create efficiencies, but eventually we will run up to a wall where there is no way that we can cut any further. Now, the benefit of the fact that we have variable costs that's really low and expense cost that's high, or fixed cost that's high, is that as we increase volume going forward, we're not going to experience material increases in our costs going forward. Again, the facility cost is already there, many of our staffing cost is already there, and so forth. Really what we're looking at in the variable costs is all the incremental medical supplies, the pharmaceuticals, the patient meals, and so forth. And that is pennies on the dollar when we compare that to the fixed cost. So again, when we look at a critical access hospital, to re-emphasize, volume is very much the solver as we continue to go forward. Now, when we talk about the financial solvency of an organization, and we talk about on the left-hand side, we have our dollars, and down here we have service volumes. Now, our cost already starts well up the axis just to open the door. But when we look at our revenue going forward, we can notice that our revenue line is at a much more aggressive line going forward. Because again, high fixed cost, low variable cost. So what we have to do as an organization is we have to calculate what level of volume we need to drive to ultimately get to a profitable position. And there is this factor for every single hospital out there. And really driving that or figuring out what that is will ultimately allow us to start to budget more effectively and to move things going forward. Now, what are the 4 strategies around how we can actually start looking at our cost report and improving things going forward? Now, the first is looking at decreasing expenses. Now, every organization has an opportunity to decrease expenses. There's efficiency gains, there's ways to leverage technology, there's different opportunities to that degree. Now, when we look at decreasing cost, again, as a critical access hospital and how the cost report works, if we decrease cost, we will also decrease reimbursements that we receive from Medicare and other cost-based payers. So again, like I said earlier, this can help improve our position, but it is not a solver for all of the financial concerns we have as a critical access hospital because of the cost report. So on the same side earlier is if we increase the spending by $1 million and we're 50% Medicare, we will gain $500,000 in reimbursement just by spending that money through how the cost report works. On the inverse of that, if we reduce our cost by $1 million and we're 50% Medicare, we're going to take out $500,000 in reimbursement from Medicare. So again, there is a balance between the different programs and the mix within those different programs that will ultimately determine how we do as an organization. But reducing cost is not a pure solver for that hospital. It will only aid you in that position going forward. Another strategy is increasing charges. Now, as a critical access hospital, I'm sure many of you are familiar with, every hospital has a price list. And the price list is the value that you charge or the cost that you charge for each of the services that you provide. Now, as you look across the country, charges vary drastically. Some facilities will charge you $2,000 for a CT, some will charge you $800. Now, the one thing I want to emphasize as a critical access hospital with how the cost report works and the reimbursement methodology is, as you increase your charges as a critical access hospital, you are increasing the portion of expense that you are passing on to those Medicare patients in the way of coinsurance and deductibles. As a critical access hospital for outpatient services, 20% of the charge is their coinsurance amount. So if you charge $1,000 for a CT scan, that patient's portion is $200. Another CAH that charges $400 for the same CT scan, again, it would be 20% of that amount. So as you look forward, increasing charges as a critical access hospital, again, similar to expense reduction, is not a sole solver for that critical access hospital. Generally, what we've seen that have led to an increase in true financial performance is a renegotiation of third payer contracts, evaluating your coding, so doing chart audits and coding reviews to make sure that we're adequately charging for the services and that we have the adequate levels for those services that we're providing. But a pure, let's just increase our charges, will not always increase revenue for that hospital. And many times it could actually hurt you as a critical access hospital. Increase volume or improve service mix. As a critical access hospital, based on all of the different factors, the nuances of the cost report, the charge structure, the expense structure, and everything, increasing service volumes, I would say, is the biggest opportunity to improve the financial position as a critical access hospital. Increasing volumes will increase the revenue we obtain. It'll dilute down the cost per unit of service. It'll help us in a financial position going forward. Now, what I want to emphasize, though, is when we talk about service volumes, this pertains to the services that we generally should be providing as a critical access hospital. Now, if we were to go back 20 years and look at healthcare, oftentimes there was the field of dreams methodology or approach. If you could get this surgical specialist to come in, let's just hire them and, that'll grow out our volume. As we've continued to move more towards telehealth and technology and the delivery of care, we have to be more tactful in how we're actually acquiring and expanding services going forward. And what we need to look at is to ensure that the services that we're providing are justified and sustained based on the volumes and the reimbursements we're receiving. Now, I'm not saying to get rid of all services that are not financially advantageous. It is okay to dedicate mission dollars to support certain services based on community demand and need. What I'm saying is we have to gain a clear understanding as to the cost to provide care to ensure we're not in a negative position financially just because we want to provide those services. But as a whole, generally increasing volume is the biggest solver for issues at critical access hospitals, more so than expense reduction or charge increases. Taking that to the next level, the next benefit is also to grow our non-Medicare business. Now, growing the non-Medicare business will increase both our dollars and our service volume. The reason for that is because our non-Medicare business is predominantly fee-for-service revenue. So every unit of service we increase, we're going to generate whatever that service we're providing times whatever the fee schedule it is. Whenever we increase our Medicare payer mix, we're just diluting down the same reimbursements that we get with the eventual goal to drop that below what our commercial rates are. So really, as a critical access hospital, we really want to start targeting, again, because of the cost report ramifications, non-Medicare business going forward in many of our outpatient services. Now, again, on the inverse of what I said earlier, this does not mean to get rid of all your Medicare business, just like we don't want to be 100% Medicare. What it's saying is to find an adequate blend of services and maintain those services going forward relative to the reimbursement structure, the payer mix, and all of those different factors going forward. It takes a blend of all four of these different strategies: expense management, charge capture, charge increases, volume growth, payer mix, and so forth. All of those different ways play into how the cost report works. Now, when we look at different strategies, oftentimes we will see failures at critical access hospitals of trying to manage to the cost report or managing our ratio of cost to charges. And really, this just puts us on a downward spiral. The goal that we want to look at is really looking at how we can continue to improve financial performance by leveraging the cost report and the distinct advantages given to us as a critical access hospital. So again, we want to continue to work forward and to improve outcomes based on those different factors. I know I've gone through a lot of information and I've done it very much at that 50,000 foot view. And really what I wanted to do as a part of the Cost Report 101 is to explain how it fits into the operational decision-making process, and really from a governance approach, how it can drive some of those different strategies going forward. What I really didn't want to do was to get in and say, oh, worksheet B-1 has these rows and columns, and you get very much at that granular level. I'm very happy to do that if we'd like to do that as a follow-up presentation. But because, as we talked about, cost-based reimbursement is very different from any other reimbursement structure that we've experienced within healthcare and other areas, or even other industries, that I wanted to explain the importance of why the cost report can't just be an administrative task for a critical access hospital, and why it has to be a part of the overall strategy for the organization. So I'm going to pause for a second. Again, if there's any questions, please submit them in the chat box, unmute yourself. I want to be able to address any questions that you may have.
Hey, Jonathan, this is Laura. I'm not seeing anything come across just yet, but thank you for your time, and everyone on the call. As you share this information, if you get feedback of, hey, we want more information on this topic or more specific information here, please let us know. We want to tailor these. We want these to be useful for your board members. So I'll take one last look. It doesn't look like we have any questions. So thank you everyone for your time. Thank you, Jonathan, for being our kickoff. And everyone have a great rest of your day.
Thank you.